Good evening, everybody. Welcome to our very important and special event. My name is Francesca Seed, and I'm the chair of the Maternity Voices Partnership in Central Lancashire. This event is extremely important and special, and it's where we, the North West Maternity Voices Partnerships, have the opportunity to ask questions and speak with the North West Vaccination Programme lead for the North West. And before I introduce myself and our guest tonight, I'd just like to go through some additional information. The event's being recorded by NHS England, and it will then be saved and broadcast so that you can access this information at a later date. It'll be saved on the NHS England YouTube channel, and that link should be available within the next 24 hours. The information that's being given to you today will enable you to make an informed decision as to whether the COVID-19 vaccination is suitable for you in your pregnancy. And the event is being moderated. Can you put any questions in the chat box that's down the side of your screen? Those questions are being moderated, and they will get processed through with our brilliant moderators that we've got working in the background. Working with me today, I've got Cathy Brewster, who is the co-chair of the Greater Manchester and Eastern Cheshire Local Maternity Services MVP, which is a Maternity Voices Partnership. She's going to be co-hosting the questions section with me when we get to it. Cathy is an exceptional service user representative. I've worked with her on many maternity transformation projects over the last few years in our positions as MVP chairs. You'll hear her in the background talking to me and Richard. When we're broadcasting, there's only one of our faces that can be shown. So we're going to have Richard's face when we're doing the questions, because he's the important person giving the information, but you will often hear Cathy and I chipping in. And I don't know if are we able to get Cathy shown on screen or not, or is that really bad thing to do? She might get shown in a bit.
I'll just say hello so you can hear my voice.
There you
Good
go.
evening, everyone.
So moving on, and because time is of the essence and we've got a huge amount of information to get through this evening, I'd really like to introduce our extremely knowledgeable and well-respected North West Vaccination Programme clinical lead, Professor Richard Preece, and he will introduce himself now, and he's also got his wife, Helen Kirk, and he can introduce you and tell you who Helen is as well. But with that, for now on, I'm going to let you take over, Richard. Thank you.
Yeah, thanks, Francesca. Thanks, Cathy, and thank you all for inviting me to join you this evening and share a little bit of information. I'm not an obstetrician. Cathy knows very well that I chaired the Maternity Transformation Board in Greater Manchester for 3.5 years up to the start of the pandemic. So it's really nice to be working with Cathy again. But with me, I have Helen Kirk, who was until recently the maternity lead for NHS England and the North. So if I've got any kind of midwifery related matters which is beyond my technical knowledge, Helen's just going to help me with that and sort of kind of keep me on track. So what I want to do first of all is just share a little bit of information, and hopefully this will help everybody with their own thinking about this important issue. It's been difficult over the last 1.5 years to not think a lot about COVID. It's dominated our lives. And I wanted to start by saying that vaccine uptake by women, particularly women in the age groups you see in front of you, is really high. Of course, it's a little bit lower in the 18 to 29-year-olds at the moment, but we've not been vaccinating them for quite as long as the other groups. But the younger women within healthcare that we've been vaccinating, for instance, since the start of the programme, the uptake amongst all NHS workers is really high. And it's even higher when you look at people who kind of work in frontline clinical work, like doctors and nurses. So these rates are really encouraging. It's also, despite some of the issues that we might touch on this evening, uptake amongst women is higher in men, higher than men in all age groups, and that's particularly true in younger adults as well. So mostly really encouraging. But what's for sure is uptake amongst pregnant women is very much lower. We can come on to that. Next slide, please. So you may reasonably ask how many pregnant women are currently vaccinated. And we haven't got brilliant data on this, I'll be absolutely honest, because we've got great data on the number of people vaccinated, but of course we don't necessarily know that they are now pregnant. We don't know always that they were pregnant at the time of vaccination, but we do know that there are at least 150,000 women who are currently pregnant who've had at least one first dose, and about half of them have had both. So we're dealing with really, really big numbers here. And hopefully we'll soon have much more accurate figures for this, because we're really keen to understand it better. Next slide, please. So I thought it would be helpful just to talk a little bit about how the vaccines work. I'm not going to cover every vaccine, because the two vaccines that we're offering to pregnant women are the vaccines from Pfizer and Moderna. And you've probably heard quite a lot about Pfizer, because we've been using that since day one of the programme back in December last year. Moderna came a little bit later. We've got 4 vaccines altogether. All of them are now licensed for all adults, including pregnant women, and that includes the AstraZeneca one and the Janssen one. But because we've got so much more experience of Pfizer and Moderna in pregnancy, we prefer to give one of those 2 vaccines, and they're basically the same kind of thing. They each can consist of a sort of little bubble of lipid, a little bubble of fat containing a bit of code, and that code is for the spike protein. And what the vaccine does is it stimulates our own cells, our own body, to produce the spike protein, and that's the little bit that sticks out of the side of the capsule of the vaccine. And that means that it's the bit that's most easily and most quickly detected if you're exposed to the vaccine, because obviously it's on the outside. And what it does in the cells is it stimulates the production of that protein, and that then provokes a normal immune response, which is to produce antibodies and T cells, which kill infected cells. Of course, none of the cells provoked by the vaccine are infected. The vaccines don't cause infection, but nevertheless, they mimic that, and that stimulates the normal physiological immune response. Next slide, please. So just a few key points then, that they don't cause infection. There have been no safety concerns found in any of the animal studies for all 4 of the vaccines, and we are beginning to get more and more evidence about their safety in pregnancy. So there are hundreds and thousands, millions probably now, of pregnant women around the world that have been vaccinated, because overall about 1 billion doses of vaccine have been administered around the world. We do know that vaccination provokes the production of antibodies, and in the same way that we do for whooping cough, for example, we vaccinate pregnant women against whooping cough, knowing that they will transfer those kind of helpful antibodies to babies and protect babies. It's a really important part of looking after babies, thinking about how we can protect them through mum. And we also know that antibodies are found in breast milk, which again we think will protect babies. The only reason we don't know for certain is, thankfully, we're not seeing lots of babies get unwell with COVID, and that again is a really good thing. But we do know they have got the potential to offer protection. So next slide, please. You will have heard that when people have had the vaccine, lots of people will say they might have felt a little bit off colour, in the same way that if you get the common cold, you might feel off colour for a couple of days, or anything else that provokes your immune system to work. We're not expecting the vaccine to do nothing. We really want it to start to build the protection in your body. Now, this is a bit of a complicated slide, but what it really shows is that although some of these symptoms are relatively common, actually these are things which are reported pretty commonly just if you give a little, kind of salt water solution as an injection. So this is from Pfizer, and you can see there, if you look at, I don't know, in the second box, fatigue, quite similar rates of fatigue between the vaccine, which is the BNT162b, and the placebo bit, which is the salty water. And the one I really wanted to highlight is the first block in where you've got pain at injection site. And the most important way, actually, when we know if you were in the clinical trial, the easiest way to tell if you had the vaccine is you're far more likely to have a sore arm. And if you talk to people who've had the Pfizer vaccine, or indeed the AstraZeneca vaccine, quite commonly, they will tell you their arm was sore. Certainly in my case, you know, I wasn't going to be sleeping on my left side the following night, but it soon dissipated. And it is your body saying, right, we're dealing with this, we're building protection. It's quite normal with all vaccines, and it's what we would like to see. Obviously, we don't want people off colour, but we do want to make sure they're building protection. What I would say is some people have been thinking about maybe deferring vaccination until after baby's born. And just one of the considerations that you should have in that regard is actually the last thing you need when you're tired with a new baby is to feel off colour for 48 hours because you've had the vaccine. Sometimes it's better to get it out of the way early, and it's never too late in pregnancy. So let's move on to the next slide. So these are the some of the risk factors. If you're pregnant, you're no more at risk of acquiring COVID than someone who's not pregnant. But if you get it in the third trimester, it's trouble. And of course, the risk of more serious COVID, the risk factors for that are the same. I'm not going to dwell on this, but to suffice to say, if you have got any pre-existing health conditions, then clearly that compounds the likelihood of being more unwell. Next slide, please. The vaccines are really effective, and when we think about vaccine effectiveness, our threshold is normally 50%. It works 50%, doesn't sound very much, but that's huge in terms of reducing the likelihood of serious illness. And actually what you'll see from this is that if you've had 2 doses of vaccine, for example, your chances of being admitted to hospital are really, really low. And that's an important point that we can return to in a couple of minutes. But suffice to say that it's the 2 doses that really matter. And actually 2 doses matter really greatly with the Delta variant, which is the one which has been sort of circulating in the community recently. And just to note to say, in those 171 women who were admitted seriously ill between May and July, none had been fully vaccinated. And only 3 had 1 dose. So that just gives you an indication of how effective vaccination might be in preventing serious illness. Next slide, please. We know that if you get COVID-19 in the later part of pregnancy, 3rd trimester, that can be real trouble for mum and baby. I'm not going to go through each number here. You can read those for yourself now or later. But what I wanted to draw out from this slide is I've given 2 things here. I've given what we call the relative risk, how much more likely is that to happen in a certain case, and also the absolute risk. And this is really important. So if I look at emergency C-section, for example, you know, you're 1.63 times more likely, but actually it's quite a common thing. So therefore, that's talking about 20% of pregnancies. Whereas if we go to fetal death, which thankfully is a very uncommon event, it does double your risk of that, but double a small thing is a small thing. 1.63 times a common thing is a common thing. And it is really important when you think about some of the information you might see, that you do think about relative risk and absolute risk. The one that really matters to you is absolute risk. Twice nothing is still nothing. So sometimes when you see relative risk, it can be really misleading. So it is important to know, what does that actually mean for me? Next slide, please. So this shows, it's a little busy, this slide, but what it shows in the blue and grey blocks is the number of pregnant and recently pregnant women who are in critical care for COVID. Now, typically in a month, there's about 30 pregnant women in critical care in the UK due to any reason. So if you to look at this, you'll see some peaks that go as high as above 60. And in July, we had close to 70 pregnant women who were actually pregnant at the time in critical care in the UK. Now, that doesn't sound a lot, but put it in the context of 30 women normally, and that is for pregnancy-related issues, it's for trauma, it's for other surgical issues, it's for medical conditions. It's really uncommon, and yet in July it was really high. Superimposed on the number of admissions, I've just put the pattern of the pandemic. Now it's on a different scale, and as you see, I've marked the peak one as 4,500 admissions. That was in a day, by the way, not in a month, but it just gives you an impression of the pattern of the pandemic. And what you'll see is that last year it kind of followed the red curve. It did the same through the end of the year and into winter in January, February, when it was a real peak. And now, as we've hit the new peak, all of a sudden the pregnant women admissions is not following the trend anymore. And that is a combination of high vaccination rates in the wider population, low vaccination rates in pregnancy, and the Delta variant, which is much more transmissible and seems to be having a much more adverse impact in pregnancy. So that's why I've shown the pattern there, because you can see in June and July, boy, did it book the trend, and that's a real worry. And it's part of the reason that I was pleased to be able to talk to you this evening. Next slide, please. So just to kind of summarise some really key messages, vaccination is safe. All the evidence suggests that. COVID-19 in the third trimester definitely isn't, for the reasons I've said. You can be vaccinated at any stage. Obviously, we'd like people to have had the two doses. That's the one that really protects you against Delta, but one's better than none. There is no evidence of impact on fertility, on periods, none of that. There's no evidence of that at all. And vaccines, whilst we don't have evidence clearly of the long-term impact of the COVID vaccines, we've only had them for about 9 months now. There is no evidence from any vaccines of long-term adverse effects. And actually, these are sophisticated new vaccines that have been developed with really clever technology. And I should say on that, actually, that people are worried about how quickly they've been developed. But actually, the technology, like the little fatty bubble, the liposome, that technology has been developed so that we can have vaccines really quickly. And it's been done because of things like Ebola in Africa, and you'll have heard about that probably. And of course, you may have known about the Zika virus, particularly in South America, that caused havoc in Brazil. So that we can deal with those kind of serious outbreaks of disease, that's why these technologies have been developed. And all we needed to do was put the new code in there, and that meant we could have a potential vaccine really quickly. Now, the other thing that happens in development is normally it's done in stages, but on this occasion, the governments of around the world underwrote all the financial investment in manufacturing. So what it meant is that as soon as the trials were done, we could just produce it straight away. That's not normally the case. That pharmaceutical development process normally takes a couple of years, and actually they were good to go from the outset because of the amount of money that was put into it. So that's really all I wanted to say. If we go to the final slide, I'm not here to sell vaccination or twist your arm to come forward. This is about choice. My only concern is that people have the information that they need from good, reliable sources to make the choices that you would like to make. And I am concerned that there's sort of a bit of mythology that might arise from time to time. Sounds plausible, but maybe not. If vaccination is not for you, think about when you might want to be vaccinated or not, then that's a fair consideration. And do remember, you can still reduce your likelihood of being exposed to COVID by applying the usual measures around social distancing, and particularly making sure the people around you are vaccinated. Even if even if you're pregnant and vaccination's not for you, then a really great way to protect yourself is to make sure your partner's vaccinated, so there's less likelihood of the virus inadvertently being brought into the home. And it is really tricky if you've got young children. We know they spread germs like wildfire, but just bear that in mind, and do what you can to make sure that if your choice is not to be vaccinated, you're doing whatever you can to reduce the likelihood of catching COVID and suffering adverse consequences. And I'll pass back to my chair now, if I may. Thanks.
Thank you, Richard. Thank you very much. Lots of important and valuable information there, and interesting information as well, which obviously will help people as they decide what is best for them as we go along. We're now going to move on. So over the last week or so, since we started advertising this event, people have been invited to submit their questions. This was so that just essentially, if nobody turned up and there was no questions coming in the comments box, then at least we had something to go off. So to people who have sent in questions, thank you. There's been lots of repeated questions as well, and lots of people with very, very, very similar concerns. So what we're going to do for this section is I'm going to work through the questions that have been submitted, and Richard's going to ask them. Kathy might chip in as well if she's got some additional information as to questions. It was Kathy that managed to pull all of the questions off the various emails that we got and put it in a list for us. So I'm going to crack on. And the first question that we've got, Richard, is I'd be grateful if you could tell us more about the specific ingredients in the Pfizer vaccine, as from researching this on the gov.uk website and then looking into all the ingredients more. There are a couple that say they should be avoided during pregnancy as they're untested. I'm 33 weeks pregnant and really still undecided about having the vaccine ahead of giving birth, and would just like to some more clear information based on science to help me make up my mind.
Yeah, it's a really great question. I have to say, when you look at what we call the excipients, which are the kind of the other ingredients in the vaccine, there's some very weird sounding stuff in there, and that of itself can be worrying. But I suppose my start point for that would be to say that I'm not even going to try to list them in detail. They are there, but it's important to remember a number of things. Firstly, the quantities are really, really tiny. So one of the things that we think about is the polyethylene glycol bit, the PEG bit, and that's there in 90 micrograms. Now, I can't even give you an analogy for how much 90 micrograms. It's a tiny, 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 tiny amount. And that's important because, of course, continually our bodies are exposed to tiny amounts of things that the body doesn't want there, and our whole physiology is designed to deal with those. When you read the small print on some of these things, it can be really worrying, because what tends to be applied is the precautionary principle. So if you're not sure, just put it in as a precaution. And to put that in perspective, if you look carefully at oxygen, which I would put to you as a pretty important part of our lives, you will find that oxygen is marked down as being toxic as well. So that's the point, really, is that there are tiny amounts of these things. There is no evidence that any of them would cause harm, and certainly not in the extremely small quantities that we're talking about. Where you have the precautionary principle, that will potentially cause a little bit of alarm, but as I say, it applies to oxygen too.
Thanks, Richard. And just on that question as well, there was one bit that I just missed up. It was from the context of the vaccine. What will pass to baby of those from that vaccine? What part of the vaccine is going to pass on to baby?
The vaccines don't cross the placenta. What does cross the placenta are antibodies that are the result of the vaccine. That's a good thing. I'm very pleased that baby's getting some protection from COVID, but the vaccines don't cross the placenta. I mean, the placenta is designed to get antibodies across there. That's a good thing. So that's why they get across.
Brilliant. Thanks, Richard. The next question is, what do you know about the long-term effects the COVID vaccine could potentially have on the unborn child? For example, in 1, 2, 3, 4, 5 years' time, it could then come to light that there's a correlation with women who had the COVID vaccine when pregnant and children have an X illness, impairment, disability. And then the person's continued to say that unfortunately research conducted over a long period of time isn't and won't be available for years to come. So how can we as mothers trust a vaccine when we cannot understand the long-term effects it may have on our unborn children? Yeah,
that's again a really great question. And of course, in the past we had all the considerations about MMR and autism, which of course was not true. But nevertheless caused great damage and great concern for people. When we've only had a vaccine for a little under a year, it's very difficult to speak sensibly and about what might happen over a 5-year period. What I would say is, and as I said in the presentation, is that there is absolutely no evidence from any vaccine of long-term adverse effects. And there is absolutely no reason to believe that that will be the case with this vaccine at all. That needs to be balanced by what I hope I've been able to show this evening, which is the very real short-term and terrible effects of having COVID during pregnancy, or indeed outside of pregnancy for some people as well. So there is a balance. Can't ever give a cast iron guarantee, but there is no evidence to suggest that.
Thanks, Richard. Moving on from that, why are we now being told that the vaccine is safe in pregnancy? However, obviously when the vaccine programme was first launched, pregnant people and breastfeeding people were told not to get vaccinated.
Because that was absolutely the wrong advice. So that advice was given right at the start of the programme. We kicked off on the 8th of December. That advice was completely changed by the 30th of December. People may remember that people around the world really reacted very badly to that. The World Health Organization severely criticised the UK government for that. There was no reason to suggest that. And actually, what I have to say is the sad thing from my point of view is we've been trying to we've been trying to recover the ground from that right from day one. But throughout the whole of 2021, the message has always been clear: when you're eligible, get vaccinated. And if you're pregnant, please still get vaccinated. Actually, we know now it's even more important. So it was a terrible piece of advice to issue right at the beginning. And although it was remedied after 3 weeks, we've never really been able to completely dispel that. But I hope that I've done I've done little tonight to reassure people these vaccines are safe, and yet absolutely, COVID in pregnancy is not.
Brilliant. Thanks, Richard. This one I think you've already answered, but we will ask it anyway. I don't think I know. I've seen your presentation. Do you have statistics on the number of admissions to hospital of COVID positive pregnant women and people over time, showing trends, particularly since lockdown was lifted, broken down into the vaccinated and unvaccinated, and clarification on how admission came out, for example, asymptomatic? Just you've covered this obviously in your presentation.
Yeah, I've sort of covered it, and because I talked about critical care admissions. About 1 in 10 women who are admitted, pregnant women who are admitted to a hospital seriously ill with COVID, end up on critical care. So when I say there were 100 or so women who were either pregnant or recently pregnant on critical care in July, that means 1,000 women who were really seriously ill on acute wards in hospitals during that month. That was after the end of lockdown. I think that answers your question. We do need to remember that more recently the higher case rates of COVID have been young people, particularly 10 to 19s, but younger than that as well. And actually lots of people who are pregnant at the moment have got other children. And they are a potent source of infection in the household. So yeah, it's been really worrying. And with Delta in June, July, really problematic. I'm hoping now that we've been working so hard to share information about the vaccination in pregnancy and COVID in pregnancy, that we'll see those. Well, we are seeing those numbers of uptake rise, and hopefully we'll see far fewer people seriously ill.
Thank you. If the vaccines have been tested in animals, and this is what the government class as safe, how can we be sure it's safe for us as humans?
Yeah, I think at this stage, the animal studies from a year or so ago are almost a bit irrelevant. In that, when as I said, we've got 150,000 pregnant women who are currently pregnant and have been vaccinated. We've got far more real world experience. So things in the laboratory will tell us some things, but ultimately we learn far more from what happens. And we've got this incredible post-surveillance program. So either today or first thing tomorrow morning, we're going to pass the milestone of 5 million people vaccinated in the Northwest. That's where the real knowledge comes from. And those very large numbers of young adult women as well who've been vaccinated, that's where the real learning is. And the animal studies were all very reassuring, but by comparison to the number of people we've now vaccinated, they don't tell us anything near as much as we get from actual real human experience.
Thanks, Richard. Why have no trials been done on pregnant women in the UK? We're expected to take advice from the US. However, when we talk about other aspects of birth, we are told not to listen to any US advice as their standards are different to ours.
Yeah, so the short answer to that is that those kind of what I'd call the phase 3 trials, which is the sort of the big human trials of these vaccines, which were done a year ago. They told us certain things. The Pfizer vaccine, for instance, was tested in numerous countries around the world: America, Germany, South Africa, Brazil. List goes on. Pfizer didn't do that particular clinical trial in the UK, but there've been lots of other clinical trials in the UK, and they've included pregnant women. Although the trials didn't specifically recruit pregnant women, there were people who became pregnant during the course of the vaccination programme for those trials. So we did get experience and knowledge before we started. But the reality is, of course, that we've learned so much more as we go on. And we learn far more from the fact that, as I say, we've got at least 150,000 women in the country who are pregnant at the moment who've been vaccinated. We learn more from them and our continual monitoring to make sure that they're okay than we would do from any kind of research study, which would be very much smaller numbers.
Okay, and just amalgamating a question further down that I've got, have any abnormalities been identified due to the fact of on babies as you know, after they've been vaccinated? Have any abnormalities been identified on babies of pregnant women who've given birth?
Absolutely not. That would raise alarm bells immediately, of course. And actually, what I would say is that it's very clear from the latest evidence that vaccination is protecting babies with Delta variant in the community. And those numbers I gave you from May till to July, where almost none of the people that were admitted who were seriously ill in that study had been vaccinated, gives an indication of the protective effect of vaccine on babies in the third trimester at the time of birth. So it's kind of almost reverse evidence in the sense that we're seeing all the benefit. We're definitely not seeing any adverse impacts on fetus.
Brilliant, thanks, Richard. What evidence is there of the SARS-CoV-2 specific antibodies in breast milk of women who have received both vaccines?
So, women who've had COVID will have antibodies to COVID in their breast milk. Women who've been vaccinated do have antibodies in their breast milk. We assume from that, as I've said, that will offer protection to the baby. That it would do for anything else, so it's reasonable. What we've not been able to show in studies yet is that contrast, if you like, to unprotected by breast milk babies with protected by breast milk babies, to see that that's absolutely the case. But everything about it suggests to me, we know that having mum's antibodies is a really great thing for babies. There's plenty of COVID out there, unfortunately. So I think we can be confident that both the vaccination is helpful to babies as well.
Thanks, Richard. How can the vaccines be considered safe when they were rushed through?
They weren't rushed through, and I kind of touched on that at the end of the presentation. As I say, I kind of see this like we'd already created the technology, we've got the vehicle, we're just changing the contents. So this is like having our little delivery truck and putting a little different parcel in the back. We'd already developed the technology, whether that's for the AstraZeneca or Janssen vaccine, style of vaccine, or indeed for the Moderna Pfizer mRNA vaccines. For the Pfizer vaccine, that little ball of fat, that little lipid ball, we'd already developed that, so we could produce new vaccines really quickly. And that meant we could go straight into clinical trials. The clinical trials that were done for these vaccines were huge compared to normal. So, 30, 40,000 participants, whereas, for a new cancer drug, for instance, it might just be like 300 or 400. This was 30, 40,000. And that was because we didn't have any difficulty in getting loads of people to come forward. Everybody knew that vaccines were, a great hope to draw the pandemic to a close. So the manufacturers were able to do really big studies. So that meant we could get really strong evidence quickly because they were so big. That was good. And then, as I said before, because governments around the world, the UK government, the Americans, others, underwrote the manufacturing process, that just meant as soon as they were proved to be safe and effective, then they could turn on bulk manufacturing. And that meant rather than wait 2 years for those systems to be developed, because companies would have had to take their own financial risk, they were good to go. It was just a case of plugging it in, and off they went, and able to produce millions of doses of vaccine at enormous pace. So it was a number of factors that allowed it to be done more quickly. The reality now, of course, is that now we've got that proven capability. If we get a new variant where we need to tweak the vaccine, we'll be able to do that in weeks, not even in months. And producing vaccines really quickly is not that new, because each year we produce a new variant of the flu vaccine for the coming season, with three new variants in. So we know how to do this, and we have done for ages. And now we're in this brilliant position that if we do have a really dreadful new variant come along that seems to be not responding quite so well to the vaccine, we will be able to tweak it and produce a new vaccine really smartly, and that's encouraging. But at least for the time being, we know that 2 doses of the vaccine is protective against all of them, including the latest Delta variant.
Thanks, Richard. The yellow card scheme for reporting adverse reactions to medicines and vaccines show that there have currently been 465 spontaneous abortions and 10 stillbirth or fetal deaths reported. Is this not cause for concern?
Okay, so the way that the yellow card scheme works is that it asks us as doctors, for example, to report anything that's a time associated, just report it. And that's how we learn. So what that means is that it's not saying there's not necessarily cause and effect there. It's saying the vaccine took place and then there was another event, in this case, a miscarriage or a stillbirth. And that's really important. But to put those in perspective, a few hundred and a few tens, we get about 250,000 spontaneous abortions a year. What's that? 20,000 a month. So we've vaccinated 50 million people across the country. It's inevitable that we will see a time association between those events, and equally true of stillbirth. It doesn't make them any less traumatic for families, any less sad. We would expect to see some association, and we've looked at that really closely, and there's been no change in from background rate. It's as we would expect it to be, which tells us that actually it's a temporal association. The way I kind of always try and describe this is that, on the 25th of December, a big fat bloke in a red suit climbs down my chimney and delivers me presents. And then in January, everybody goes down with flu if we're not careful. I'm pretty sure that Father Christmas is not responsible for flu a month later, but there is a time association. And that's what we've got to be careful about. So it's right to report everything on the yellow card scheme, because we want to learn, and we won't find any issues if we don't. But just because it's on the list of things from MHRA that have been reported, that doesn't mean association. It just means they've been reported, and we would expect to see that. Surprisingly, for those 2 things, spontaneous abortion and stillbirth, the surprising thing is we haven't had more reports, quite frankly, because we would have expected to by just by chance.
Yeah, and it's also important, obviously, to remember that 1 in 4 pregnancies will end up sadly in child loss, through miscarriage or other reasons as well. So moving on, because time is huge. We've got through so much information, and you are just a vat of knowledge, Richard. You can have a drink. What is the DNA source for the mRNA in the vaccines? I know mRNA is transcribed from DNA. That's how it's made, but no one knows what the source is. I'd like to know. That's not me, that's the person asking.
Yeah, no, that's great, isn't it? It's funny how we've all become geneticists, isn't it, in the last course of the last year. So mRNA, the M in mRNA is just the messenger, and mRNA is that little bit of, kind of usual circumstances. You've got your normal, genetic code in your DNA. That's the stuff they do on CSI detect your criminals. We've all got a big chunk of that. And then the mRNA is the bit that takes the little message, so it's the messenger RNA to the production system for proteins. But you can just make it. This is a case of, clever scientists in a lab with a chemistry set, and they put it all together and they just add the acids together to make it. So it's not from animals, it's not from any other source. It can just be easily created in the same way that we can do very, very sophisticated things with DNA testing now, the same way we can just link these things together. Nucleic acids are really clever. So they sort of naturally slot together. So as long as you put them in the right order, it'll do the right things. And that means we can create the code to make the spike protein, which means we can then produce the antibodies and the T cells and create the immune response.
Brilliant, thank you. I went to go for vaccination and I was asked to confirm for a disclaimer that you are aware that there's been a trial in the US which has showed no safety concerns. However, there's not enough research in the UK to say it's safe in pregnancy. Asking at my antenatal appointments and being told we do not know if there are any long-term impacts to your baby, so it's personal choice. I'm being recommended to self-isolate until birth, as I'm yet to be vaccinated. I would like to know what the true guidance would be for someone who is 36 weeks, being induced at 40 weeks, and who is able to isolate at home between now and then.
Okay, gosh, that's a tricky question, isn't it? So first to say is that I wouldn't be so downbeat about all evidence from America, but like any evidence that we have, whoever presents it, and I'm no different in that regard. We have to think about that and just evaluate its quality. So what I would say with the number of people that we vaccinated now is that huge amount of what we call real world experience, where we've been able to track what's happened in the actual setting of normal people in normal settings being vaccinated. And that's the most important of the lot, because we measure that in millions of people in that, if you like, great big monitoring scheme, as opposed to, thousands or hundreds or whatever it might be in a clinical trial. But as I said in my presentation, it's never too late to be vaccinated. So it doesn't matter. It doesn't matter where you are. If baby's due tomorrow, you can still be vaccinated today, should you wish to. If you're in the latter stages of the third trimester, you can still be vaccinated if you want to be vaccinated. It's entirely up to you, and clearly you're in a risk group. It is possible, of course, to completely isolate yourself, and that will mean that you can't be exposed. But in doing that, you do need to think about the other people that could expose you. If it's only you and your partner, and your partner's been vaccinated, well, your partner's likelihood of catching COVID is dramatically reduced, but it's not zero, and the likelihood of transmitting it to you is dramatically reduced if they have COVID, but it's not zero. So I would say you've got to make your own choice in that regard, and decide when's the right time for yourself and your family, and think about doing all the other things that will protect yourself. So we can't deal in absolutes here, but if the person asks a question wants to be vaccinated, then they're very welcome to be vaccinated at any stage in the pregnancy or thereafter, and that offer is always on the table for them.
Thanks, Richard. And finally, from the pre-submitted questions, there's a person here who has been vaccinated, received both vaccinations. They've also had COVID, asymptomatic COVID. They work in care and they are wanting more information on receiving their booster vaccine. Currently working in general practice and 15 weeks pregnant with the first child. So just wondering if there's any information that's been given that you can give yet with regards to receiving booster vaccines, which will be offered to that person.
Yeah, so we're just waiting for final advice about booster vaccines, and that's for good reason, because there are two big studies that are going, which I call ComCov and CovBoost, which are really saying what's the most effective way to do a booster to the primary course. What's the best vaccine for that, and what's the timing? Are the vaccines interchangeable? And they're due to report anytime soon. So we're expecting JCVI, which is the Joint Committee on Vaccination Immunisation, that's been advising the government that people will have seen, to produce advice on that shortly, but waiting for those 2 studies. So in terms of that specific question, the person asking it has had 2 doses. That's great. That's the baseline for protection against Delta variant, particularly in the 3rd trimester. But you know, as we get advice coming through about who should have a booster and at what point, then that'll be the point that that question can be specifically answered. But it looks very likely that you know, ask me in a few weeks' time, and I'll be saying to the person asking, yeah, get along and get yourself vaccinated now. This is the right time.
Thanks, Richard. So time is definitely creeping up around us. It's now 7:15. We've got 15 minutes left of this event's time. We're just going to quickly have an overview of the BRAIN acronym, which we use when we're trying to explain to people the best tool in order to help them make a decision. And that, I think we're sharing it. So you can see this BRAIN. I would hope that anyone, not just in pregnancy or using maternity services, in any form of using maternity services, would use this tool to help them make a decision. You can Google it. It's very much easy to find. And basically, whenever we are being have a choice put before us, we should look at what the benefits are, what the risks are, what the alternatives are, what your intuition is. So what is it really, how do you feel about it that's being told, and what could you do if you did nothing at that time? And I think that your presentation, I know your presentation has explored every aspect of that BRAIN acronym. That's definitely a valuable tool for service users to help make an informed decision, but also service providers as well, to enable them to provide the information to help facilitate that decision to be made as well. And you have been very clear, Richard, as well. You know, this is a choice for people to make. It is their decision in what is best for them, their baby, their families, their circumstances. It isn't always as black and white as we want things to be. It would be very easier sometimes if people just told us to do things and we didn't have to think, you know, but then that does take away that right of choice, and it's really important to make sure that you are informed and you're happy with the decision that you're making. Have you got anything to add before we move very quickly? I'm going to do 5 minutes, probably 5 to 10 minutes on looking at what's been coming through. There's loads of questions flying through, and Kathy hopefully is going to work her way through. But is there anything that you want to add quickly about enabling choice, Richard?
I just think, just to reinforce what you said, Francesca, which is that, you know, these are not straightforward decisions. You know, it's always difficult to know what the best thing to do is. You know, and you know, whether you're a pregnant mum or whether you're dad, and I've got experience of the dad bit, but not the pregnant mum bit, and you know, it's always challenging to know exactly what the right thing is, particularly when there is different advice out there. Some of it's good, some of it's not so good. You never quite know where to go. And I would just say that you know, try to find those reputable sources of information. Don't believe you know, everything you read, particularly on social media. Do try and check it out as best you can, and then make your choice. And you know, we're going to respect that, obviously. And if your choice is have a vaccine, I'll be going, yay, good, and we'll get you vaccinated. And if your choice is not now, the door's always open, and we'd love to see you in due course.
Brilliant. Thanks, Richard. Let's hand over to Kathy, who's going to give it about 8 minutes. Kathy, I'm going to be doing some frantic waving on the screen that we can see each other on. Off you go, Kathy.
Yeah, no problem. So we've had quite a lot of comments and questions. So I'll start off with this one. Someone's just saying, thank you. This has been really informative and reassuring. I'm 36 weeks. Oh, sorry, I am 36. I'm 20 weeks pregnant with twins. They've been worried about the decision, but they think that they would like to go ahead, and they're wondering, would I be able to have it at my local hospital? And then we've got another question about the optimum time between doses for someone already in the 3rd trimester who's not yet vaccinated. So how do you get your vaccine, and what are the intervals between the two?
Okay, so yeah, well, somebody's got the work cut out coming up, haven't they? So yeah, so what I would say about that is that you know, it's relatively straightforward to get vaccinated. So you know, we can make sure that, I think the links have gone to the chat box. I'm not quite sure. I assume they have. Not been looking at it. But it's easy. So my advice to you, if you just Google NHS COVID vaccination, the booking website flashes up straight away. That's dead easy to do. If you tap in walk in vaccination, then it goes straight to the what we call the grab a jab website, which means that tomorrow morning, if you're minded to, you can get along to a local service and you can just walk in and get your vaccination tomorrow. So there are different ways to do that. The optimum interval between vaccines is 8 weeks, but in some cases where the first vaccination has been quite late into pregnancy, colleagues sometimes do the second vaccination a little bit earlier, because where we can, we do want people going into the third trimester, having been vaccinated, and it takes about 2 weeks to peak the protection. So, we ideally want people vaccinated a good 10 weeks before third trimester. But the reality is the vaccination at any time is helpful. But the premium interval is 8 weeks. That's the kind of sweet spot for maximum effect.
Brilliant. OK, next question. I have had COVID before getting pregnant. Do I still need the vaccine? Any thoughts on that one? Yeah,
absolutely. And there's increasing evidence of that, actually. What it does mean, of course, if you've previously had COVID, is that there's a bit of priming of the system. But we also know that if you don't get vaccinated as well, we see significant amounts of breakthrough infection. So my recommendation would always be get yourself vaccinated, even if you've had the infection before. That won't stop you getting it again.
OK, brilliant. So a question about any considerations for having the vaccine if you're taking anticoagulant medication, either during pregnancy or after, because obviously that's been in the news a lot around AstraZeneca and clotting. And so any advice on that one?
Yeah, so of course, we saw a lot of media coverage about the AstraZeneca vaccine and the not easily pronounced thrombocytopenic thrombosis issue, which occurs in about 1 in a quarter of a million people potentially with the AZ vaccine. We're not giving the AZ vaccine to pregnant women normally. We usually give them, as I say, the Pfizer vaccine or the Moderna one. There's been no issues with thrombosis or indeed thrombocytopenia or with those vaccines. That will never be an issue to stop them being vaccinated. What I would say is that COVID, the disease, plays absolute havoc with coagulation. It wrecks your arteries into your lungs. That's part of the sort of pathological mechanism. So if you're at risk of clots, you definitely don't want COVID, the virus, knocking around. So it's a really good reason to get vaccinated, actually. You don't want to face that assault on your system. One of the key things, although we think COVID's all about, the lungs, because we see all those people being ventilated, the reality is part of the way that it caused so many problems with other organs is through coagulation. So having a bit of an issue with coagulation is a good reason to reduce your risk by having Pfizer or Moderna.
OK, shall I make this the last one? A quick one. Someone here saying their midwife hasn't had a vaccine, so how can they recommend it if they're not having it themselves?
Yeah, I think that's a really good point. It is difficult, but people come to these conclusions for different reasons. We often give advice and information to patients that we don't follow ourselves in all sorts of settings. Just because someone else has made a personal choice, and when you're making a choice about your own vaccination, you're making a choice about you. You're not making a choice about your professional practice. So sometimes people will come to those conclusions for whatever reason. Sometimes they'll come to those conclusions for reasons that they don't want to disclose as well. So you've got to be a bit careful about that. But it's obviously a real encouragement when your midwife or your obstetrician or your maternity team go, yeah, we've all been vaccinated, go for it. It's really disconcerting if one of them says, no, I haven't. But we do have to respect the fact that we all have choice. I'd like all midwives to be vaccinated, but I also recognise that some of them haven't for all sorts of different reasons, and we absolutely should respect that. But I would put it in the context of if I followed all the advice that I gave to my patients, then I'd probably be a lot more of a dull person than I think I am. I might go and have a glass of wine afterwards. I'm going to say that to torment all of you, because you're not allowed to drink wine at the moment. But you know, we don't always follow our own advice. And equally, if I take the example of people who've got certain religious beliefs, they may be very against termination of pregnancy, but we still expect them to give really good advice and information about termination of pregnancy. That's part of their professional responsibility, even if it's advice that they wouldn't take on board themselves.
Brilliant, thank you very much.
I think, Kathy, we can squeeze one more, and if you go dead quick, we've got 2 minutes before I'm going to start closing. We've got 4 minutes, go.
Oh, really? Okay, then. In that case, people have been talking about getting different kinds of information from different healthcare professionals, and it's being a little inconsistent. And also, when they have actually gone to have the vaccine, they then get given kind of warnings around it's only been tested in America and this kind of thing. So that kind of makes them feel wobbly about it. Any advice?
Yeah, no, I absolutely get that, and I'm kind of working hard behind the scenes to make sure that we're getting the advice as consistent as possible. But in the same way that everyone on the call's got their own questions, professional colleagues have got their questions as well. Last year I was working on the Nightingale project in Manchester, and I was doing a presentation to the audience, and someone said to me, "Oh, it's really great to have an expert, to be able to ask questions of." And I said, "Well, none of us are experts. I mean, the disease didn't, exist 6 months ago. We're all learning together, and we are still learning together." So what I would say about that is that, we're doing as much as we can to make sure that we've got really great information out there for our midwives or obstetricians, our nurses, or the members of the maternity team. But they've also got a busy day job. So whilst I might be really up to speed with the latest info, they can't always be exactly up to speed as well. They've got 1 or 2 other things to do as well. So I know that sometimes the advice, the messages is not absolutely crystal clear, and that just kind of mounts up the anxiety levels. But we are doing our best to make sure that we are arming our midwives with really accurate information. And in actual fact, today we've sent out a whole new batch of information to help them with those conversations, so that we can be confident that people in the front line, whether they're the midwives or the vaccinators, are being really clear as far as they reasonably can with pregnant women who are considering vaccination.
Perfect. 1958, 2 minutes left. It's also just important to point out that information that has just been sent out to service providers has been put through service users as well. So we did go through that information too. So which was just, it's fantastic that we are being used, service users are being used to help produce these materials. Importantly, links are all in the comments for if you wish to book a vaccination, or if you want to look for any information to help you to continue making this decision. I am going to say a huge thank you to the people in the background that you can't see. We've got some people who are making this work, doing all the clicking and the things like that. So a big thank you to them. As very, very muchly appreciated. Thank you. Kathy, you have been, as usual, a superstar. Helen is there next to you, Richard, and I know that she was there to if we got any questions with regards to pregnancy or anything, thank you, Helen, for being there and for jabbing him to let us move on to the next question to shush. And most importantly, Richard Preece, thank you. It's been an absolute pleasure. I have worked with you, and your knowledge is just, I can't say the word phenomenal, but it really is. And I know that you are highly respected and thought of, and you really do promote choice in everything that's going on. And I just want to give you a huge thanks. In a normal forum where we'd all be in a big room, we'd be given a huge round of applause, and so you can't hear that. But thank you very much for coming tonight, answering these questions honestly, filled with facts and information, and most importantly, to help inform people's decisions as to whether the COVID-19 vaccine is for them, and whether they wish to have it or delay it or not have it at all, that their choices will always be respected, and that their choices that are presented to them will always be enabled and informed. Thanks, Richard, very much.
My pleasure.
Thank you. We're going to leave you now to enjoy the rest of your evening. Thank you, everybody.
Thank you. Bye-bye.